Oral Assessment 3.1 Characteristics of Relapse Situations of Alcoholics Treated with Aversion Conditioning. The authors are interested in stimulus control, the principles of which dictate that an alcoholic is likely to have their first post-treatment drink in an environment similar to which they used to drink. In the context of aversion treatment, however, the same theory of stimulus control would suggest that those treated with aversion therapy would in fact be more likely to have their first post-treatment drink under different environmental conditions. The authors' aims for this study were to determine whether this is the case, whether alcoholics treated with aversion therapy relapse in the same general location, social environment, and with the same type of alcohol, or if these factors are different. The participants of this study were alcoholics who presented to hospital for treatment in the past and had since relapsed and returned for further treatment. Each of the participants had, upon their initial stay, undergone a rigorous aversion therapy treatment regime. The therapy took around 30 minutes and was conducted every 2 days. It consisted of injecting an ebetine hydrochloride to induce nausea. The patient then had to drink an alcoholic beverage before the onset of nausea and vomiting. There were 10 to 30 pairings of various alcoholic beverages, but predominantly with the patient's favourite beverage. For their research, the authors conducted a relapse questionnaire with each of the participants with questions on preferred beverage, locality of drinking, drinking companions, and if they had a reaction to their first post-treatment drink, such as nausea and vomiting. The length of sobriety for patients ranged from half a month to 93 months. The average length was 17.6 months, and the most common length was 8.8 months. Only 5 had nausea, and only 3 were frightened upon having their first post-treatment drink. The questionnaire showed that 75% of the patients had their first post-treatment drink that was the same as their favourite drink before treatment. The patients relapsed equally alone as with others, and twice as many patients relapsed away from home as did at home. However, when changing the question from most frequent place before treatment to most frequent drinking environment to not most frequent drinking environment, the difference jumped to 81%. The fact that most patients relapse with their favourite beverage without any negative side effects suggested to the researchers that there needs to be an effective method to assess whether patients develop the aversion to alcohol from the treatment and also whether their booster sessions are required to reinforce the aversion over time. Researchers concluded that because the majority of patients relapse in non-typical drinking environments, that this should be taken into consideration in behaviour modification and counselling settings. And aversion therapy should be conducted in a variety of environmental settings to generalise its effects. There were limitations to this study. The authors acknowledge that the cohort of participants are far from typical. They were patients from a private treatment hospital, previously having undergone very rigorous and intense aversion therapy, suggesting that they were particularly highly motivated to quitting. The researchers hoped that the fact that these patients had since relapsed and returned to treatment would reduce the selection bias. Another possible limitation to the research was the use of self-reports. They acknowledge that many clinicians doubt the veracity of the answers of alcoholics give to questions regarding their behaviour, but they point out that when interviewed in the research context where no action would be taken to change their behaviour as a result of their answers, they found them to be forthcoming and reliable. When comparing the interview questions to patients' records from the hospital, the researchers found that there were no inconsistencies between the answers. The authors also point out that their relapse questionnaire was not specific enough as to determine the social environment in which patients first relapsed. They suggested that perhaps if they had changed their questions from drinking alone or drinking with others to drinking in most frequent social situation to not in most frequent social situation, then perhaps they would have collected more robust data and seen a similar correlation to that they found in the locality questions. There are other limitations that the authors don't discuss, but they are evident. There is no control group for the research to determine whether patients who did no aversion therapy had the same or different relapse rates, first drink post-treatment preferences, or if they relapsed in similar locations and similar social situations. By not having a control group, the researchers have no information on how alcoholics from the same cohort of patients relapsed and therefore whether the aversion treatment played any part in the results they found. The researchers also failed to mention by whom the patients were interviewed and whether the interviewers were aware of what the research hypothesized. They may have been inadvertently recording answers they were expecting to find, or coached the participants to giving answers they expected to hear. The researchers tried to control for the possibility of patients lying in their questionnaires by comparing their answers to those of the hospital records. They found large inconsistencies in regards to the date of previous admission and the number of aversion treatments, but largely consistent results to those recorded at the hospital regarding the questions of the environment and type of beverage, leading to the conclusion that the responses were truthful. But the variability with only the hard data that the hospital recorded, for example, the treatment types, frequency, and admission dates, and the consistency in only the data that the patients themselves gave to the hospital suggests only that the patients were consistent in what they tell hospital staff and what they told the researchers, but not as to the truthfulness of that information in either case. The use of a retrospective research design and questionnaire greatly limits the conclusions that can be drawn from this research. Thank you for your time.